So for the final part of this presentation, I'll be talking about pharmacokinetics in acute kidney injury. The overview is shown here and very similar in topics to what we've already covered for chronic kidney disease. As we've mentioned, drugs are commonly prescribed, and particularly in patients with acute kidney injury, they're generally admitted to hospital and they're acutely unwell. So we need to think about how our dosing regimen may differ to that for patients with normal kidney function. So AKI is a much more complicated scenario for CKD. And that's because AKI varies in severity, duration, and also its treatment. We get changes over a much shorter time frame than we would in chronic kidney disease. And as already mentioned, it's often observed in the context of critical illness. So we're getting multiple other physiological impacts. So changes in kinetics seen in patients with acute kidney injury may actually reflect more about changes in critical illness or changes related to sepsis rather than AKI on its own. So there's multiple factors which are impacting on measurements of pharmacokinetics in these patients. AKI has ill-defined impacts on biochemistry and clearance, and this includes the clearance of drugs, electrolytes, and also uremic toxins. I've already shown you that uremic toxins can impair non-renal clearance. Well, with the AKI, it might mean that they're increasing or decreasing at rates at which we don't understand. Maybe that doesn't even change to a significant extent. We're just not sure. There's not enough data. So the net effect of these various issues is that there's marked variability in drug concentrations and patient response. And therefore, if you were to look at drug dosing guidelines, they tend to be very vague or even absent because it's too hard to comment on them. But we need to think about this. As you're aware, there is an epidemic of acute kidney injury. This is the way it feels, at least to me as a nephrologist. It seems to affect more than 20 to 30% of patients admitted to hospital worldwide. Many of these cases of AKI are very low grade and they resolve rapidly. But patients with more significant AKI, particularly if you go to intensive care, the mortality may approach 23%. I've already mentioned that sepsis is a major cause, and since antibiotics are used for the treatment of sepsis, then it's crucial that we obtain appropriate concentrations of those antibiotics to ensure that we're maximizing clinical outcomes. Many of these patients who come in with acute kidney injury have complex comorbidities, and they're taking multiple drugs. And so this increases the overall risk of management in acute kidney injury. And so we need to dose adjust these medicines. As you probably know, in many cases when someone comes in with acute kidney injury, we find ourselves stopping a lot of medicines. So that can make some decision making easier. But there are a number of medicines we don't stop, and there's medicines we start. And so we need to have an approach to dosing. And patients who have acute kidney injury or critically unwell may receive a renal replacement therapy, such as dialysis, which may also impact on clearance and pharmacokinetics, but I won't be talking about that today because that's the topic of another presentation. So how do we diagnose acute kidney injury? Well, again, it's based on serum creatinine. And the way we stage acute kidney injury is based on how high the creatinine rises relative to the baseline. So here, stage 1 is when it's up to 2 times the baseline, or if it raises by more than 0.3 milligrams per deciliter or 26.5 micromoles per liter. If it goes up to nearly 3 times, it's stage 2, and if it's more than 3 times, it's stage 3. Or if the person has a serum creatinine concentration that increases by more than 4, and there's also other markers which relate to urine output. So this tells us about the stage or severity of acute kidney injury. Note that this is not telling us what the actual kidney function is. It is not telling us the GFR. Why is that? Well, similar to what we were talking about before, we can only use creatinine to interpret kidney function when we're at steady state, and AKI is a dynamic condition. If we look at a scenario here, these are some simulations based, which were published in 1975, which there are a few assumptions made, but even still, I think it's a very useful representation of what happens in real life. If you have an acute event that all of a sudden drops your GFR to 25%. It takes a few days until you get to a new steady state. If your GFR drops down to 5%, it takes much longer, and that's because the half-life of creatinine becomes so much longer that the time to steady state is much longer. So what we're seeing here is that your creatinine concentration is changing constantly over days. You'll often see written in the notes, certainly where I live, where people write down evolving AKI, progressively deteriorating kidney function. Not true. Obviously, that depends on the scenario. We're seeing the creatinine going up, not because the kidney function is getting worse, but because we still haven't got to a new steady state. So that means that in the onset of acute kidney injury, whatever the creatinine concentration that we see, that underestimates the actual kidney function. If we were to put that number into, for example, Cockcroft-Gault or a CKD epi formula. And so therefore, those formulas don't apply. If we compare them to the recovery phase, what we can see here is that as the kidney function is improving, you'll get, we need to give time for the kidney function to come down, for the creatinine to come down. So any measures of creatinine during a recovery phase understate how good the kidney function is, meaning that the kidney function is better than you would estimate from the creatinine during a recovery phase. So this demonstrates why we shouldn't be using eGFR to measure GFR to estimate the kidney function for the purposes of drug dosing in patients with acute kidney injury. There have been some more complex formulas that have been developed which look at the rate of change between two creatinine measurements, which can then be used to predict kidney function or GFR at that time point. But they're not routinely used because of their complexity. And we've got an acutely dynamic situation. This has led to exploration into alternative biomarkers of acute kidney injury. And you can see here, for example, in this older paper now, cystatin C is mentioned there. I've used this clinically and I've done research using cystatin C. Similarly, I've done it using NGAL as well. Some of you might have also been involved with studies looking at these other tests. These other biomarkers show damage at an earlier stage and help to quantify GFR compared to these later stage measurements that we use, such as serum creatinine. So what's the impact of acute kidney injury on pharmacokinetics? Well, this is a short presentation because essentially we don't have much information. What happens with absorption and metabolism? There's extremely limited data. As it happens, we don't give oral tablets or capsules or formulations to many patients with severe acute kidney injury, but sometimes we do. And so there's very limited data, and the data that we have is confounded by the critical illness, which frequently has its own impacts. What about volume distribution? Well, again, this is quite variable. Often it will increase in acute kidney injury, but this is largely because the studies where this has been measured have been critically ill patients with sepsis and acute kidney injury. In these cases, the antibiotic volume distribution has been shown to vary tenfold or even more, so it can be quite significant. And this can be impacted on by multiple factors. For example, we give lots of IV fluids during resuscitation. These can all increase volume distribution. Vasoplegia and capillary leak can cause edema and pleural effusions or ascites, which further increases the volume of distribution, and there can be changes in protein binding. Similar to the discussion that we had with chronic kidney disease, this, as you can see, is all largely changes in water, not in, for example, adipose tissue. And therefore, changes in volume distribution are more likely to occur in antibiotics or other drugs that are hydrophilic. This is some real data in patients who are critically ill with acute kidney injury who required continuous renal replacement therapy using the drug meropenem. What we can see here is that despite separation of two different doses, 500 milligrams and 1000, there is no clear separation in the concentration time profile. So each concentration time profile here reflects a different patient. And we can see here that some patients have extremely high concentrations and some patients have extremely low concentrations and very different rates of elimination based on the half-life. So it really shows a lot of heterogeneity between these patients within the population. This then impacts on, for example, with meropenem, differences in the trough concentration. And that's important because the meropenem being beta-lactam-like drug, the carbapenem, its main determinant of efficacy is a time above MIC, and therefore this would suggest that we're overdosing some patients. Tazobactam, piperacillin, the same. Vancomycin, there was a lower target seen in some patients. This is showing the impact of sepsis on antibody concentrations. So we can see here, if we compare volunteers with those with sepsis who received piperacillin, and this is looking at, this is the plasma concentration here. So we can see here that patients with sepsis given the same dose of piperacillin compared to volunteers have a much lower concentration and a longer elimination half-life than we see with volunteers. So this is important because it probably reflects an expanded volume of distribution, but we don't know if there's also impact of clearance here as well. And so is this important? Well, it depends on what the MIC is. Being piperacillin, it's time above MIC that's most important, and whether or not these concentrations are above the MIC or not. The same matters also apply when we're looking at muscle and subcutaneous tissue concentrations, where there are marked differences between the patients who are volunteers and those who have sepsis, where generally the concentrations are lower in those with sepsis. And this is probably a volume of distribution issue, but all of these patients also had acute kidney injury. There's very few studies looking at patients with acute kidney injury. I myself have tried to do it, and it's very difficult to recruit patients because when they're presenting to hospital who are acutely unwell, it's very hard for them to consider consent-related issues. But of the few studies that have been performed, they're all in critically ill patients, and therefore there's other factors that are present. It appears that change in kinetics that there is not nephron dropout. Considerations around intact nephron hypothesis that we discussed with CKD may not apply in acute kidney injury. And this is because the relationship between filtration, active secretion, metabolism just is still too poorly defined. An interesting study looked at what happened with patients who had a unilateral nephrectomy. So this is a useful marker or model for acute kidney injury, because with that, when you surgically removed a single kidney, it's similar to a decrease in your GFR by 50% all of a sudden. So they compared what happened with atenolol and amikacin. And so 1 month post-operation, clearance was reduced in both atenolol and amikacin. And as you know, both of these drugs have a high proportion that's renally eliminated. But at 12 months afterwards, clearance had almost normalized for atenolol, but not amikacin. So it suggests that there's been some sort of compensatory process during that time. We know that when you do remove one kidney, then there is an increase in filtration in the opposite kidney. That's what we call hyperfiltration. And so therefore this may allow for some compensation after removal of a kidney. Whether or not this occurs in other models of acute kidney injury or other patients admitted to hospital with acute kidney injury, for example, due to sepsis, we don't know. And as mentioned, this may relate to hyperfiltration of the remaining kidney. Maybe it also relates to changes in uremic toxins, we're not certain. Animal studies also don't support the intact nephron theory when we're talking about acute kidney injury. For example, in some cases, transporters, there may be increased expression. For example, if you do a 75% nephrectomized rat, you get an increase in the expression of some transporters. There may be an overall decrease in clearance because of the decrease in nephron mass, but there is a lack of proportionality, for example, for drugs that would be substrates of these transporters. And sometimes some of these changes may rapidly resolve. So this may relate to hyperfiltration of the remaining nephrons. In some cases, there may be decreased expression. In some cases, we get differences in expression depending on what the cause of acute kidney injury is. For example, NSAIDs, which can cause acute kidney injury, may protect against changes in organic anion transporter downregulation. But if you look at an ischemia reperfusion model of nephrotoxicity, then OCT may be downregulated. And some of this may perhaps relate to hyperfiltration of the remaining kidney. Really more data is required. How do we quantify GFR in patients with acute kidney injury? As already mentioned, we can't use the regular formulas because of changes in creatinine. So if we go back to this slide, E-creatinine clearance and eGFR are based on a single creatinine, and the assumption there is that you're at steady state conditions, and we're not with acute kidney injury, so you cannot use them. You can do a measured creatinine clearance, and this has actually been done by a number of clinical groups, but also research groups. For example, if you've got a person in intensive care who's catheterized, you could do maybe an 8-hour urine collection and estimate the creatinine clearance based on that. You can also get a measured GFR. For example, send them to, in my hospital, it's done through nuclear medicine, where they may give DTPA or inulin or MAG3. This can be used to measure the GFR at that time. Of course, though, with acute kidney injury, there can be changes. So you need to have a really good reason for measuring that and acknowledge that tomorrow, maybe even 6 hours later, the GFR may have changed. So in conclusion, this is a summary slide showing how we may get changes in patients in pharmacokinetics in patients with either acute kidney injury or chronic kidney disease. I've gone through most of this information, so I'm not going to read it to you now. I'm presuming you can pause the slide if you'd like to read specifics into these. I've also added the impact of doing kidney replacement therapies or dialysis, although that was covered by another talk. So in conclusion, acute kidney injury and CKD impact on the pharmacokinetics of many drugs, but data are limited for many drugs and also many scenarios. Despite these changes, there is also marked individual variability, and so that really does complicate the development of dosing guidelines, whether based on something at the institutional level or something at the patient level. The failure to properly account for the effect of kidney disease when prescribing and inadequate monitoring can predispose our patients to treatment failure adverse drug events, which we want to avoid. Thank you.